shared meal, no outings. So if you think about this incredible isolation that occurred, so the ability for us to be there by telehealth gave an incredible dose of predictability and normality. And I would joke, but it's kind of a heartbreaking joke, right? I was the only unmasked face that many of my patients saw for months at a time. And, I think we all think back to, when we were all masking all the time, the ability to see someone's nose and mouth, is an incredibly normalizing experience. And so to be able to be there consistently and still have those conversations, right? Still have those therapeutic interactions. Many of my residents said, like, this has been my lifeline, and it was. Some have smartphones and tablets, and so they were able to Zoom with friends and family. But many individuals who end up in SNFs and ALFs are those with the least resources, right? And so not having access to any of these things. And the staff would try, they often will have a tablet, and so they would try and set up some of these Zoom calls, but then the family member or friend needs to have access to that technology as well. So it really was incredibly isolating. And the declines in physical, cognitive, and emotional health that we saw were profound. But again, if you think about, someone who had been really active within the facility, going to all the activities, having communal meals, really interacting with people, then being confined to their room for, 3 months, 4 months, we really do. We lose those interactions. They have profound physical, emotional, spiritual, and cognitive impacts. And the inability to have family visits, again, absolutely heartbreaking. What this meant was that we had to work even more closely with the facility staff to try and find some options, to try and find some ways to provide support. That included providing more support to the facility staff, helping them manage their fear and anxiety, because they were frightened as well. Kind of going home, staying in a separate part of their home from the rest of their family, because they didn't know if they had been exposed. They didn't want to bring home, anything to family. And so it was so disruptive and so frightening on every level. So I want to expand a little bit. That was the experience working within SNFs and ALFs, but I think there is such rich potential for those of us in behavioral health care to work within a variety of medical settings. This is something I've really been passionate about since graduate school. I took as many health psychology classes as I could when I was in school, and that interface, again, mind body, that I think we're simply learning more and more about the interaction. And so there's a dramatic increase in the awareness of mental health. I'm so glad that, again, as kind of a culture, we're starting to talk about this more, recognize it more, that the level of kind of shame and the expectation that people will hide, emotional struggles and challenges. I think it's improving, and I want it to improve. And there's more interest and opportunity for mental health professionals to be included in traditional healthcare settings. That allows much greater access for more people to get that care, and it decreases the stigma. And so if you're working as a mental health professional embedded within a medical setting, people then can come have visits with you without that same stigma. They can come and see their primary care physician and have a visit with you on the same day. And those things that increase access and availability, I think, are absolutely wonderful. And it also allows medical professionals to have a better understanding of what it is that we do. I've lots of friends who are physicians, and kind of almost to a person will talk about how little, right, emotional health, behavioral health was discussed in any of their training. The same thing is true about nutrition, right? That you talking about food, but that it's starting to be more of a topic, that recognition that, again, body, mind, and spirit are not separate. We're kind of housed in that same container. It's important to address all of those. And as mental health professionals, we have a unique combination of skills to help navigate these challenging circumstances. And there's so many ways, kind of depending on what your interests are and what your passions are, to tailor this. You know, the recognition that emotional health impacts physical health, that anyone going through a significant medical issue, you know, whether someone has been diagnosed with cancer, someone has been diagnosed with Parkinson's, that the very experience of being diagnosed, you know, creates emotional reactions. And so there's so many ways that we can provide care and support. We can help our healthcare partners also manage their own stress, because again, the healthcare system has certainly been under incredible strain. So many people have left the profession. A lot of nurses left the profession. We are starting to see them coming back into facilities now. So, you know, people who had quit, like, I can't keep doing this, kind of about a year into COVID, are really missing providing care, starting to come back in now that they've been able to take a little bit better care of themselves. Their burnout level is much improved. And so again, but we're kind of adapting and we are adjusting as these changes occur as well. And so being able to provide care to, you know, to residents, to patients, being able to support staff, being able to provide education to staff about, you know, mental health issues. We find this a lot in SNFs and ALFs with neurocognitive issues, that, you know, any of the dementias, because what we find is that a huge proportion of the staff who are working in these facilities have had absolutely no education in dealing with neurocognitive issues, dealing with dementia. They don't understand what's happening. The term I'll hear really often is the patients are being naughty, right? And so there's this interpretation that someone who is acting out in their dementia, not something they are choosing, right? This is it's a brain change, is somehow choosing this. And so when you can get the staff to make that shift from, you know, thinking that this is kind of a volitional choice, to understanding that it's part of a disease process, it sets them up to have much better interactions. It sets them up to be able to provide much better care and to have better quality of life for the residents. And so then I want to, again, kind of take a little bit more macro. Being a mental health professional, it is, you know, absolutely an honor for me every single day. And it's one of those professions that we really can get better as we get older. You know, there are some professions that you're like, all right, you're kind of at your peak. And being a mental health professional, we can continue to grow, and our life experiences simply make us better clinicians. The wisdom that we gain, the wisdom that we gain from our, you know, from our clients and our patients. That idea that we're always learning more life experience, and it gives us more tools in our toolbox, and that's a pretty amazing thing. And so, kind of keeping that commitment to growth, and to adding to your toolbox is really important. And I feel really strongly about a commitment to science, right? To keeping up with what the research is saying. Because that adds to, especially if we're working with, you know, within a medical setting, to be able to help our patients understand, you know, what's going on with them, what's the latest information, keeps us vibrant, keeps us adapting, and it keeps the information that we're sharing with the people that we're treating as accurate and up to date as possible. And there are pretty exciting things that are happening, again, within the world of certainly kind of neurocognitive disorders and treatment, and mental health disorders and treatment. And I'm really pleased at the kind of the focus on the answer is not a pill for everything, right? And that what we have to offer as mental health professionals should be the first line of treatment, instead of handing somebody a pill and having that be the first line of treatment. And so that, again, I think that's being recognized more and more, and CMS is certainly, with their oversight, getting, you know, those who are prescribing to think more mindfully about what they're prescribing, why they're prescribing it, And certainly with older adults, that you'll end up with this incredible polypharmacy that, they've just been added, tons of medication, and then, medications to treat side effects of medications that they're on. And, having medical professionals take a really long look at that, to say, what's the minimum necessary? What are we really targeting here? And that's where our expertise to be able to say, let's add some behavioral options in here. Let's look at the emotional components of this as well. Makes a huge difference in the quality of the lives of our patients. Again, not just in SNFs and ALFs, but certainly in the population as a whole. It's important, I think, as a mental health professional, to listen to our reactions, right? And the issues and populations that resonate most with us. And that may change over time. I started my career at the VA hospital in Washington, D.C., working with combat veterans. They will forever be in my heart. That is such a passion of mine. Working with trauma again, and so that kind of informs all that I do. Being aware of trauma, but after 5 years, I was really burned out working day in, day out with combat veterans. Quite honestly, had less to do with the veterans and more to do with working for the VA and its bureaucracy. But being aware of our own reactions, and at times the need to kind of make a change or have new challenges, that's okay. That is important, and kind of leads into that next piece, that we need to practice what we preach. And so kind of being aware we have to care for ourselves. We truly are, as mental health professionals. We're kind of the tool that we take into every interaction. And so making sure that we're taking care of ourselves, that we are, we're practicing what we're preaching, and that very modeling, our patients see that. They know it, whether consciously or unconsciously, if we're not caring for ourselves, if we're not, practicing the very same things that we're asking them to do as well. And so it's kind of a nice reminder. But just again, that willingness to be able to kind of adapt and to learn new things, I think is incredibly important. And I just kind of want to wrap up. And so, kind of this final overview, our healthcare system has been so deeply affected by COVID. I think those kind of shock waves still continue. For anyone who has tried to get an appointment with their healthcare provider, or tried to get an appointment with a specialist. And again, I hear this from friends, I hear this from family, I certainly hear this from patients. It's been really challenging. Many physicians have left, the profession as well, or they've left, kind of. I live in Chicago, right? So they've left Chicago, they've gone out to the suburbs because they were just kind of burned out with being in the city. And so I continue to hope that there will be some really positive changes that can happen within the healthcare system that allow providers to give great care to people and not to feel like they need to run on fumes all the time as well. But the idea that anything is kind of, can be both a stressor and an opportunity, and how do we do that alchemy, right? How do we create gold from what kind of appears to be base metals? I think is what for, as humans, right? One of the things that we can try and do. How can we create something, better out of something that's been so incredibly stressful? And it's not easy. And kind of going back to, that burnout piece, it's also okay if you need to step away for a little bit, if you need to take a break. As a mental health professional, we absorb a lot of stories, we can absorb a lot of trauma. And so to know when you take a break, when you need to take a break, and to have that be an ongoing, part of your own self-care is really important, because if you don't, it will catch up with you. I mean, it catches up with all of us. And so if that's just kind of an ongoing part of your own self-evaluation, it can really make a huge difference. And getting the support, getting the supervision that you need, because we all need supervision, as long as, as long as we are doing this, getting some fresh thoughts, some fresh eyes. It's honestly one of the things being the CPO at MetaTelecare now, where all of the psychologists and social workers at the company, they report to me. And I love getting to know our clinicians and talk with them and getting to, learn what their passions are and try and find ways for them to kind of share those within the company. All of that is really, really important, because we're all in this together. And that piece of lifelong growth and evolution, and not to be afraid to think out of the box. That creative thinking to offer some suggestions or come up with some new strategies for doing things. Just because we've always done something in a particular way is not a good reason to continue doing something in a particular way. And that really is such a pivotal part of what we have to offer. And I want to say that I was and I'm incredibly excited now that CMS has finally, said that they will allow counselors, to be part of this. We at MetaTelecare can't wait until we can start to hire counselors within, because CMS has not allowed reimbursement, which is absolutely ridiculous. Don't get me started on that. But I think, the counselor education is so powerful, and I think it's a wonderful fit for the issues and challenges that residents in SNFs and ALFs struggle with. And so that is just going to be an additional wonderful opportunity that I think is going to benefit everyone nationwide as counselors are able to step into more roles that you are absolutely more than qualified and able to do. Thank you. I am happy to have questions and dialogue, and anything I can do to try and answer, I certainly will. Cassandra, should I open up the chat?
I think the chat is open. We've had a little bit of conversation in the chat. Somebody mentioned that that there was a great outlook that pills don't solve problems. They often create other problems. I'm inclined to agree.
Absolutely. Yes. And again, particularly in older adults, and one of the things that we will find, I'll go on this is a little bit of a soapbox issue for me. One of the things that we will find, and it's certainly not something that I had dealt with a lot prior to working with this population, and that is delirium versus dementia. And so, delirium is a transient state, and all sorts of things can create delirium in somebody. Somebody can become septic and have an episode of delirium where they are incredibly confused, hallucinating, delusional. All of these things happen, when people are delirious. And in older adults, UTIs are not uncommon, and UTIs can lead to delirium. And I cannot tell you the number of times that I've seen, an older adult, someone that I know that suddenly I go in to see them and they are really, really psychotic. They are delusional, they're seeing things, they're hearing things, they're delirious. But the number of times that either someone would then put a dementia diagnosis on this person if they are older, that then is incredibly difficult to get that inaccurate diagnosis removed, or a psychotic disorder diagnosis, and the person will be placed on antipsychotic medications. What we're talking about is delirium. And so that education, and I'm talking about, by the staff. And so it's gotten to be my, when I see somebody, I'm like, can we please get a urinalysis, Can we please get a urinalysis? Have you done a urinalysis? And 99% of the time they'll come back and they'll be like, oh, there's a UTI. Person is on antibiotics, and the next time you see them, they are absolutely fine again. But that information, that knowledge, and so whatever systems in which we are working to also make sure that we're knowledgeable about this. I had an absolutely lovely resident who, when she was about 62, had a very severe fall, broke her femur, became septic, after that femur fracture. And for about 4 days, she was delirious and really wacky. It was delirium. It cleared completely. But her 2 adult children took this opportunity to get guardianship. And somebody somewhere put a dementia diagnosis on her. And I could not get the diagnosis to go away. I tested this woman 6 times, cognitively, absolutely strong. But it is so hard when someone's independence and rights have been removed to get them back again. And those things should never be done lightly. They should never be done easily. And sometimes there are all sorts of secondary gain and hidden agendas that families can have. And so, those of us who are treating these patients, again, what's in the best interest of the patient, making sure that we are providing the most accurate information possible. And if we see things like that, to say, I don't think this is an accurate diagnosis. Sometimes it's incredibly hard to even figure out where it came from. But it will absolutely follow and dog people. Sorry, that was a long tirade.
We've got some other conversations going on in the chat. Jose Lopez mentioned that mold and other toxins can also lead to anxiety. And Jeff Rice mentioned that the geriatric population gets misdiagnosed frequently.
Absolutely. Yes. Yes. And one of the other things that I find, particularly when we're talking about older adults, they did not grow up with the same psychological mindedness that we have today. And so some of the measures that are commonly used, that language doesn't resonate with them. And so you can give a GDS, geriatric depression scale, and it may not accurately reflect the person's experience, because that's not language that they're going to use. They don't, that's not what they've ever described. And so being aware of that, and that also absolutely goes into kind of taking into account cultural issues as well, right? Not all cultures express themselves the same way. And you have to look at that kind of broader picture when you're trying to see what's going on with this person. Just because they don't use the word that we think they should use does not mean they're not having an experience, and to understand that experience. But I absolutely like that, just misdiagnosed so much of the time. And again, that those diagnoses just follow people. Sometimes you'll see, right, someone was admitted to the emergency room, somebody there, puts a diagnosis on them. They end up, being transferred to a skilled nursing facility. They just then assume that diagnosis is accurate. I mean, it really is the self-perpetuating problem. And so to say, I want to make sure, the attending physician is really looking through this, or the nurse prac, go through the medications. Why are they on these? Do they need to be on them? GDRs, gradual dose reductions, are incredibly important, so that people are on medications they need to be on, and at dosages that are effective, and for lengths of time that are appropriate, all of those things.
There's a question in the chat from Elizabeth Fincher. She wants to know, this is from somebody else. It says, how do you balance advocating for these patients/clients?
Absolutely. And that's a great question. It is challenging at times when you see care that is less than ideal, right? And the staff at facilities, 99% of them are absolutely wonderful. There aren't enough of them. I think, they would tell you they don't get to provide the level of care that they would like. And so it's hard to make sure that we're not setting up an adversarial relationship when we see these things. When a resident says to you that they waited an hour and a half, to be changed because they're incontinent, after ringing the call bell. It's hard. I wouldn't want, again, I wouldn't want to be left for an hour and a half in a wet bed. I want someone I care about to be left in a wet bed, but sometimes there simply aren't the staff, and there are kind of urgent things that need to be done. And so it's very hard to strike that balance where you are advocating for the patient and for what's best for them, but not creating an adversarial relationship. I end up with my patients who are cognitively strong, really helping them be able to advocate for themselves, being able to speak up, being able to be assertive when they need to be assertive. And like many other things, the better we are at building the relationships with the facility staff, the more they're able to kind of hear those things from us. Or like, hey, can I help you come up with some strategies for doing this? And sometimes they really do. I end up doing a lot of in-services with the facilities to kind of talk with them, primarily on memory care units, again, because those can be the most challenging, and sometimes the behaviors really are very difficult to deal with. But helping them have strategies where they feel like they are working together instead of working at cross purposes for one another, or kind of being proactive instead of reactive. Because for most of us, when we're in that reactive mode, not when we're making our best decisions. And the more that you're kind of in this, you kind of learn what battles to fight, and that there are some that just that this resident needs to be up and in their chair every day at 9 a.m. may not be a reasonable expectation, but to say, okay, that they really do a lot better when they're able to be up and kind of out. And so can this be part of this process? And then you work with the patient to say, all right, when they come in to help you get up, please don't say no unless there's a really good reason. Because if you've asked the staff to do that and they're like, all right, we're going to go in and do that, and then every time the patient says, I don't want to do it now, the staff are going to stop asking. And so there's a lot of sometimes it feels a lot like doing family therapy. It really and truly does. That you're kind of having to work with a lot of different personalities and a lot of limitations, but when it works well, it's amazing. And when you see the staff say that made a really big difference. I was working with a memory care unit, really caring staff, but they had not been educated all about dealing with dementia patients. And so they had a resident who he fully believes that he is at work, right? And so with a dementia patient, you're not going to convince them, that what they believe is not true. They time travel, right? And the answer is not to frustratingly, reorient them. It doesn't work. They're not going to remember. You have to kind of flow with it. And so he thinks he's at work. And so he was trying to, what he thought, like leave work at the end of the day. And 6 staff people converged on him at the door. And he got aggressive because through his eyes, he thought he was trying to leave work and 6 people were trying to stop him. And so just, again, getting them to say, getting the staff to say, what does he believe? Flow with that. Don't work against it. I had another resident, not appropriate for ongoing psychotherapy care because she's really, her cognitive impairment's really profound. She was a nurse. She believes she's at work. Okay, again, not going to convince her that she is not at work, but giving her, she loves sitting with other people and she thinks she's providing care just talking with them. And so when the staff could make that shift to saying, can you please sit with Mrs. So-and-so? She can really use a little extra attention today. She will sit and talk to people all day long. She is happy as a clam. She thinks she's right. She thinks she's working, providing this wonderful personal care. She's not, she's not being intrusive. It's a win-win. And they're pairing her with patients who really do benefit from that social interaction. But when you can get people to, again, like stop banging your head, it's the drop the rope, right? When you keep pulling on the rope and it's not budging, drop the rope, let's find another way. And so it's a wonderful opportunity as mental health professionals to be able to say, let's find a different strategy. And then you watch the staff and their stress level drop when they have some tools in their toolbox that work, that are effective. And then when they feel like they're working together, because working on a team, it just feels better. When you know somebody else has your back, when you have a plan. I talk with them a lot about kind of having keywords for one another. that really does help.
And then Dr. Brown, we have one more comment in the chat. We have about 5 minutes left.
Perfect.
This is from Elizabeth. It says counselors can also work with OT and speech therapists to reduce the risk of hospital and SNF acquired delirium.
Absolutely. Absolutely. There are so many ways to kind of work with the other staff, and depending on what your areas of interest and passion are, it really is kind of limitless. And that's part of what I love so much about it, is it's never boring. There's such variety in what as a mental health professional we're able to do. And I really like collaborating. I've always liked kind of working with other healthcare professionals. So it's been a really nice fit for me. But absolutely. And again, there's so many other areas. I end up working a lot with the activities, the recreational activities people as well. And sometimes some of them are incredibly talented and thoughtful, and some have had virtually no training. And so they're really open to kind of feedback and dialogue as well. If they're working on memory care units, some specific strategies for working with patients and activities. I'm really passionate about music and the kind of therapeutic power of music. And there's some pretty cool research on what's really effective. And so I'll, when activities directors are open to this stuff, I will happily talk their ear off about kind of adding that kind of just to the milieu. I like things that can possibly really help and don't have bad side effects.
And Jose Lopez also brought up another great point in the chat, that with the baby boomer population, geriatric care is going to grow in the future. There's a lot of
absolutely. One more kind of quick piece, and this is again not something that I had anticipated before working with this population. There are more and more, and this varies from kind of region to region, area to area, but what we're finding is a lot of chronically mentally ill, right, who are ending up in long-term care facilities. So if you think about somebody who's been homeless for many, many years, perhaps again, living outside, then gets frostbite and has an amputation, where are they going to end up? They're going to end up in a skilled nursing facility. And so there's a lot of cross population now. It used to be that SNFs and ALFs really were just older adults, and they're not. And some facilities, and again, depending on the states, and some states which have closed so many of their state hospitals. So some will have a huge population of very, very, chronically, severely mentally ill. And that is such a challenge for the staff who are not trained to deal with this. We're not talking about psychiatric staff. We're talking about, LNAs who CNAs, some RNs, but they're not trained for this, and it can be really, really challenging as well. And so, some of our clinicians love working with that, right, severely and chronically mentally ill. And so there are times when we'll have, a psychologist and a social worker paired in a building. We'll have the psychologist really working with the severely, profoundly mentally ill, and then the social worker really working with kind of the more traditional kind of long-term care, adjustment, grief, loss issues. But it really, there are certainly long-term care facilities that if you went in them, you would think you were in a state hospital. The level of severity is that profound.
We have about 2 minutes left. If anyone else has any questions or comments to add, we have about 2 minutes left. Dr. Brown, I don't know if you.
Okay. No, I thank you so much. And I probably should. I'm really passionate about talking about these things. I encourage all of you, again, explore, change, grow, add to your toolbox. And I want to thank you for your very thoughtful questions and your attention today. I greatly appreciate it.
Thank you, everyone.
Thank you.